We're now thinking about chest injuries and the effects of chest trauma. And the first thing I want to do is look at a condition called a pneumothorax. But before we do that, we're going to go back and look at the way that the lungs are ventilated, the way they're inflated, and the importance of these pleural membranes. So as usual, let's start off with a diagram and build your diagram up with me as we go along. So here we have a trachea, and this is going to break down into the left and the right main bronchus. And these go into progressively smaller bronchial tubes, but basically they go into each lung. So this is going to break down into two because the left lung has got two lobes. It's going to break down into three because the right lung has got three lobes. And they break down into progressively smaller bronchial passages and into the lung tissue. And the lungs, that's the left lung there, and here we have the right lung here. And the lungs are filling most of the thoracic cavity. Of course, there's the heart and major vessels in there, but most of the volume inside the thoracic cavity is going to be filled by the lungs. So we've got the left lung and the right lung. And of course, round about the lungs, we've got the thoracic cage, the ribs. How many ribs have people got? Well, there's 12 pairs of ribs. 10 are attached to the sternum via costal cartilages, and the other 2 on each side are called floating ribs. They're not attached. So there we have cross sections of the ribs. And between the ribs we have the intercostal muscles. On the outside there's the external intercostal muscles. And on the inside there's the internal intercostal muscles. Have you ever eaten barbecue spare ribs? You know, when you barbecue ribs, the meat you're eating on those ribs is actually intercostal muscle. That's what the meat is. So the 2 sets of intercostal muscles. And of course these are forming a complete airtight seal around about the thoracic cavity. Trachea goes up a bit. And of course there's also seals in the neck. Your neck doesn't leak. But that's also sealed. And the diaphragm domes all the way up and separates the abdominal cavity from the thoracic cavity. So here we have the domed diaphragm. The sheet of muscle, the dome-shaped diaphragm. In fact, we'll just look at these on the models now just to help our understanding. So on this model here, we can see the clavicles and we can see the ribs. The ribs are counted from the top, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And as we see, the blue on this model is the costal cartilage that's connecting the ribs to the sternum in the middle. Although this model doesn't show intercostal muscles. But if we look at this in more detail, we can notice that the diaphragm domes right up the way like that. In fact, that's the start of the bottom of the sternum there, so you can see how far the diaphragm is going up. Underneath this, of course, we've got the left lung, and this is the heart here going towards the left side. And on this model we can see that the lungs are exposed, the ribs have been taken away, and we have the left lung and the right lung Notice also that there's major blood vessels going through the thoracic cavity. Taking blood to and from the heart. And there's also major blood vessels where the blood vessels go into the lung, the hilum of the lung, taking blood vessels into the lung. Now you probably already know that in order to breathe in order to inspire, to facilitate inspiration, the diaphragm has to go down. So if you put your hand on your tummy now, do that for me, put your hand on your tummy, take a breath in, and you can see that your hand goes out. That's because the diaphragm is going down. So the diaphragm goes down, in fact the diaphragm partially flattens. Active muscular contraction flattens the diaphragm. The intercostal muscles contract, particularly the external intercostal muscles contract, and that pulls the ribs up and out the way. So to breathe in, the diaphragm goes down, the ribs go up and out. And the diaphragm going down and the ribs going up and out is going to increase the volume of the thoracic cavity. If the volume is increased, the pressure is going to be reduced because there's now a greater volume, so the pressure is reduced. This reduces the pressure in the lungs. It generates a negative intrathoracic pressure. That means that the pressure inside the lungs is now lower than the atmospheric pressure outside, so air is sucked in to equalise the pressure. Then during expiration, the diaphragm will relax and move up, and the intercostal muscles will relax, allowing the chest to fall back in again. So the diaphragm goes up, the ribs and intercostal muscles go back in, the chest wall goes in. Both of these effects are going to reduce the volume of the thoracic cavity. If you reduce the volume with the diaphragm going up and the ribs going down and in, if you reduce the volume, you're going to increase the pressure. And when you increase the pressure, the air is going to be blown out of the lungs. And there's another effect aids expiration as well. Another effect aids blowing out. You probably know that in the lungs there are millions of alveoli. And the alveoli are a bit like this balloon. They're elastic. So it takes active muscular contraction to blow them up. But once they're blown up, it will let itself down because the walls are elastic. So there is elastic recoil in the alveoli. The lungs are elastic and will naturally expire. So breathing in requires active muscular activity. Breathing out is a process of passive recoil. So the last breath you will ever take on this planet will be a breath out. When someone dies, everything relaxes. When it relaxes, the diaphragm goes up, the ribs go down and in, and the person will breathe out. But it's a little more complicated than this, because around about the lungs we have the pleural membranes. So, we've got a membrane surrounding the surface of each lung, and a membrane surrounding the inside of the thoracic cavity. So let's try and draw these membranes now. Now this is the parietal pleural membrane that I'm now drawing. It goes around the inside of the thoracic cavity. So if you open the chest, take out the lungs, you'll see this glistening smooth parietal membrane, parietal pleural membrane lining the inside of the thoracic cavity. And also lining the surface of the diaphragm, lining the superior surface of the diaphragm. And each lung is in its own pleural membrane. So that is one pleural membrane, one parietal pleura. And it's physically attached to these structures. It's physically attached to the diaphragm. It's physically attached to the inside of the thoracic cavity. But then surrounding the surface of each lung is the visceral pleural membrane, the inside one. So the outside one is the parietal, the inside one is the visceral pleural membrane. And this is actually a continuous membrane. It reflects back, and this goes over the surface of each lung. And this membrane is actually physically attached to the surface of the lung. The term is it invaginates the surface of the lung. It's physically attached to it. So this physically is attached to the surface of each lung. Going round there, and again along the base of the lung, that part, and it's continuous with the parietal pleural membrane. And it's the same on this side. So there's a visceral pleural membrane here. And this is continuous with the parietal pleural membrane here. Again, lining the surface of the diaphragm, lining the inside of the thoracic cavity. And again, continuous with the visceral pleural membrane. So each lung is completely surrounded by its own pleural membrane. Now, what this means is that when the chest wall moves up and out, let's imagine this pen is the, imagine my hand is the chest wall and the pen is the parietal pleural membrane. When the chest wall goes up and out, the parietal pleural membrane is going to move with it. And when it goes back in, it's going to go back down with it. So the parietal pleural membrane is going to move with the chest wall. And it's the same here with the diaphragm. When the diaphragm flattens, the parietal pleural membrane is going to go down with it, because the parietal pleural membrane is physically attached to the diaphragm. Now I want to show you why this is important by using two acetates. So let's imagine that this first acetate here is the parietal pleural membrane. So if this is attached to my hand, which is the chest wall, then when the chest wall moves, the pleural membrane is going to move with it. So inspiration, expiration. Inspiration, expiration. That's the parietal pleural membrane physically attached to the chest wall and the surface of the diaphragm. Now this is the other pleural membrane here, and remember this is attached to the surface of the lung. Physically attached to the surface of the lung. Because when the chest wall moves up and out, we need the lung to go with it. If the lung doesn't go with it, we will not be increasing the volume of the lung. If we're not increasing the volume inside the lung, we're not going to reduce the pressure, and therefore air will not be sucked into the lung. So when the chest wall moves up and out, we need the lung to go with it. So how is this done? Well, the pleural membranes are layers of thin fibrous tissue, very similar to these acetates. Now I've got a parietal pleural membrane here in my hand, and this is the visceral one on the table. And when I lift the parietal one, we see that this comes up, but the visceral one stays where it is. But that's because these acetates are dry at the moment. And in life, there is a layer of serous fluid between these two membranes. So we can simulate this by putting some water on. Now we've got a layer of fluid between the two membranes. And this is important because when we want to breathe in and out, there's going to be some relative movement between the visceral and the parietal membrane. So it's important that there's this lubricating serous fluid between. Now sometimes you get infection in here. What do you call it if we get infection in the pleural membranes? Well, if you've ever had it, you'd certainly know it's a very painful condition called pleurisy. And that means that when there's movement of the pleural membranes, there's pain. Because this parietal pleural membrane, especially, is very richly innervated with nociceptors. It's very pain sensitive. Now, what I'm going to do now is I'm holding the parietal pleural membrane, not the visceral. In fact, I can move the visceral up to show you I'm not cheating. So there's the visceral underneath, there's the parietal on top. Now when the chest wall moves up and out, the parietal pleural membrane is going to go with it, and because there's this suction effect between the parietal and the visceral, the two membranes are going to move together. And of course, remember the lung is invaginated by the visceral pleural membrane. That means when the chest wall moves up and out, the parietal pleural membrane moves up and out. Because the visceral pleural membrane is attached to the surface of the lung goes up and out. That increases the volume of the lung, that reduces the pressure, and that means the air is sucked into the alveoli to blow them up. So when it moves up and out, the alveoli will blow up. So let's just look at this on this diagram. Here we have the parietal pleural membrane in my hand. And remember, this is attached to the chest wall. Here we have the visceral pleural membrane, which is attached to the lung surface. And we've got a layer of fluid in between, with a slight negative pressure in between the two. That means when the chest wall moves up and out, the parietal pleural membrane goes with it, and the visceral pleural membrane goes with it automatically, bringing the lung with it, expanding the lung. This is how the lung expands. Vital piece of physiology, the pleural membranes. So that's fine. That's fine. That's what happens normally. But suppose for some reason the potential space between these pleural membranes is converted into an actual space by the presence of air. Well, let's think about how this could happen. There's several ways. One way is that there could be penetrating chest trauma. Someone could get stabbed, impaled, or shot in the chest. So there's a knife there sticking into the chest. And when that's pulled out, that means there's going to be a communication between the air in the outside and the potential pleural space. Air's going to get into it. Or alternatively, there could be blunt chest trauma. This can happen after falls or road traffic accidents when there's deceleration injuries. And that could result in a laceration to the surface of the lung. Now, if there's a laceration in the surface of the lung, then that means that there's going to be a laceration in the surface of the visceral pleural membrane as well. And that means that air can get from the alveoli in the lung through to the potential pleural space. Or there could be a rib fracture with sharp ends that's been pushed in the way, and that could go through and tear into the visceral pleural membrane and the underlying lung. So in trauma it can be penetration or lung laceration. This is quite important. This means whenever there's a chest injury, we have to have a high index of suspicion for it. because obviously with penetrating chest injuries there's a risk of this air getting in, the pneumothorax. But also what people are less aware of is there might be no penetration of the chest, but there could be a blunt injury to the chest that's caused lung laceration. So there might be no holes on the outside. Air can still get in to the pleural space from the alveoli. So it can go from the outside to the pleural space, or it can go from the inside to the pleural space. And in fact, some people, particularly tall young people, can get a spontaneous pneumothorax due to a rupture in the visceral pleural membrane, allowing air to get into the potential space. And it's called a pneumothorax. Pneumo means air, thorax is thoracic cavity. Pneumo means air, like pneumatic tyre has got air in it. It's a pneumothorax. And a pneumothorax is particularly a problem with chest trauma or if there's a spontaneous pneumothorax. Now, what will this mean? Well, at the moment I'm holding the parietal pleural membrane and everything's working fine, but now there's been a stabbing injury or a laceration injury in the inside, and air has now got between the visceral pleural membrane and the parietal pleural membrane. There's now a layer of air. Now the parietal pleural membrane is okay because that's attached to the chest wall. That's not going anywhere. That's fine. But there's now a layer of air. So let's see what happens to the visceral pleural membrane. Oh, well it's gone now, hasn't it? Because there's nothing holding it onto the parietal pleural membrane. And what this means in practice is the lung will collapse. So the alveoli that did have air in them, they're no longer being held out, therefore they'll just collapse. The alveoli will collapse and the whole lung will collapse. So what will happen is this whole lung will just collapse into a relatively small volume. So here we have a collapsed lung. It's now collapsed in the way. Now the visceral pleural membrane will still be attached to the lung surface around here, but there's now a gap between the visceral pleural membrane and the parietal pleural membrane. And what this means is all this space will just fill up with air. There will be a pneumothorax all the way up to the parietal pleural membrane. All this will be air. And at this stage, we would call this a simple pneumothorax. Air has got into the pleural cavity. So how would we recognise that this had occurred? Well, normally, if we take the normal lung, there's air going in and out of all the bronchial passages all the time. And if we listen to the normal lung, we can hear the air going in and out of the bronchial passages. And if it was a human being, I could hear the air going in and out of the bronchial passages there. But on this side, if I put my stethoscope over where there should be air going in and out, well, there's no air going in and out because this air is stagnant. So there's going to be reduced breath sounds on the affected side. Reduced breath sounds. And as well as that, normally, when I percuss the lung, when I tap it, tap the chest, what you're tapping is a combination of air in the lung and the lung tissue. But now if I tap on this side, there's air but less lung tissue. So this is actually more empty than the healthy lung would be. And this gives what you call a hyperresonance note on percussion. It sounds like an empty drum because this is more empty than it was before. And as well as that, because the patient's lost the function of one lung, the patient can be quite unhappy and even distressed because they're not breathing properly. And in fact, there can be hypoxia and there can be hypercarbia as a result of this. And when we do a chest x-ray, we would notice that the lung fields are darker than normal. So, what are we going to do about it if this happens? Well, if there's an external wound, this can be called a sucking injury. There'll be air getting sucked in and out. And in a trauma situation, we can normally see that fairly readily on the surface of the patient's chest, not forgetting the back, of course. You've got to look all around the chest. And what we need to do there is we can put a dressing over that. And what we want to do is seal this dressing on 3 sides, not all together. Now, if we seal the wound all together with an airtight dressing, that means hopefully less air will get in, but maybe some air will get in, but the air won't be able to get out if we seal it completely. So we put an occlusive dressing on there, air won't be able to get out. And sometimes in trauma, you can have like a flap of tissue, and that will let air in, but not let it out. In other words, there can be a valve letting air in, but not out. So when there's actually a hole in the patient's chest there, the air can get in and out. That's not good, but it means that air can get out. Because if the air can't get out, the pressure in this side can build up. And you get more and more pressure in here, and that can start to push across. And of course, what we've got here is the major blood vessels going up and down here, and the inferior vena cava from below. So if this starts getting pushed across under pressure, then what we'll start doing is pushing the heart across. The heart will start to get moved across like that by this pressure. And that will start kinking the large blood vessels. And that's going to occlude venous return, and that will cause shock and death. That's a pressure effect or a tension effect. We're going to look at that separately, so I'm not going to comment on it further now. But it's important to realise that we shouldn't seal the hole off completely, because we can get a tension pneumothorax. So what we do is we seal the dressing, an airtight dressing, off on 3 sides. This will mean that when the patient breathes in, it's going to close off. And then when the patient breathes out, the air will be able to get out. So basically we're forming a flutter valve on the surface. So if we've got a dressing adhered on 3 sides, then hopefully we're going to avoid air getting in, because when the patient goes to breathe in, it'll close off. But then when the patient breathes out, some of the air will be able to get out, and we're going to avoid the tension effects. But basically, the definitive treatment for this is we're going to need to give the patient a chest drain, an underwater sealed drain. And I have one of these here. Now this needs to be inserted surgically. We need to carry out a complete aseptic procedure. But the basis of the treatment is that this chest drain goes into the the 4th or 5th intercostal space. So 1, 2, 3, that's the 4th, that's the 5th. And we want to be going just in front of the mid-axillary line. So it's going to go into the patient's chest about there. It's an incredibly painful procedure because, as I've mentioned already, the parietal pleural membrane is exquisitely sensitive to pain. It's got lots of nociceptors. But once that's in, I think you can maybe focus in on that and see there's lots of little holes in there that are going to let the air out. So once that's in, it will let the air out, which is good. But of course, at the moment, this tube is open, which means the air can also get in. So what I need is a way of letting the air out without letting any air in. In other words, I need a valve on this tube. And what we've traditionally done is we've connected this to another tube here. We connect that to another tube there, and we get a completely airtight seal between two tubes. And I'm going to lift this up so we can see it better. Normally it would be on the ground, but what we have here is an underwater sealed drain. And I've coloured the water in this red just so you can see it. But we'll keep this down low below the patient's bed. And let's see what's happening now with this. So this tube is now inside the patient's potential pleural space. Well, it's not a potential pleural space, it's an actual pleural space now because it's filled with air. There's a pneumothorax. So that is in the chest. So when the patient breathes out, that's going to increase the pressure in the chest. Because it increases the pressure in the chest, it's also going to increase the pressure in the pneumothorax. There's going to be an increased pressure between the two pleural membranes. And then there's increased pressure in the air in the pneumothorax. It's going to blow some of it out. The air will be blown down the tube and we're going to get bubbles. So when the patient breathes out, we're going to get bubbles. But then when the patient breathes in, they're going to generate negative pressures in their chest. Therefore, the pressure in the pneumothorax will also be reduced, and that's going to try and suck air in. But when it tries to suck air in, because the tube is below an underwater seal, it might suck the water up a little bit, but you certainly won't generate enough negative pressures to suck the water very high. And remember, this is on the floor below the patient's bed. So actually when the patient breathes in, you're probably only going to get about, maybe about that much movement. And we look for this, bubbling and swinging. So remember, when the patient breathes out, we're going to get bubbles. And then when the patient breathes in, we're going to get an upward swing. So we notice swinging and bubbling. But the main thing is that the air is getting out of the pneumothorax and can't get back in. Now, we might need some surgical procedure to close up the original hole, or we might wait for that to heal, but this can be left in for a few days while the chest heals, and then when the chest is healed, there's no longer a hole, then this can get taken out, and hopefully the patient should be absolutely fine. There'll be a little bit of air left in the pleural space when this is taken out, but that will simply be absorbed over time, and the normal negative pressure between the visceral and the parietal pleural membranes should be restored. So this is the diagram out of the pathophysiology book actually. We can see the trachea. In this case that will be the right main bronchus. We can see the rib in the chest wall. This area would be the intercostal muscles. And here we see the outer pleural membrane, and last time we drew that in blue, so we'll do the same. So here we see the outer pleural membrane along the inside of the thoracic cavity, top of the diaphragm, through the chest. And in health, immediately adherent to that, we have the visceral pleural membrane. And the visceral pleural membrane is directly attached to the lung surface. So this area here would be the lung. But unfortunately on this diagram below, not a big pneumothorax, this is just a little one actually, but we can see that we've still got the parietal pleural membrane adherent to the chest wall and the surface of the diaphragm. This patient is sitting up, so the air's gone up the way, because it's lighter. It's a relatively small pneumothorax this, so the bottom part, the pleural membranes are still together. The visceral, remember, is in green. But here the lung has partly collapsed. And here we can see that the visceral pleural membrane is no longer in contact with the parietal pleural membrane. So the lung here has a smaller area because it's partly collapsed on this diagram. And that means that this area here is now the area of pneumothorax. It has air as opposed to air and lung tissue.